Without further ado, I think I'll jump straight into the slides. We can either have a Q&A at the end of the session. People are also free to drop the questions in the chat, and perhaps I can try and answer that, either during the course of the conversation or subsequently. So as Mr. Makhdoom said, I think we'll have a little conversation around a possible roadmap for TB control and elimination in India. I wanted to start with providing a brief introduction about FIND, the Global Alliance for Diagnostics. So FIND, as an organization, we seek to ensure equitable access to reliable diagnostics around the world. As an organization, we endeavor to connect countries and communities, funders, decision makers, healthcare providers, and developers to spur diagnostic innovation and make testing an integral part of health systems across the world. FIND was established in 2003, so we'll be shortly celebrating our 20th anniversary as a product development and delivery partnership. FIND is also a co-convener of the Access to COVID-19 Tools Accelerator. I'll talk a little bit about this on my next slide. We are a WHO collaborating center for laboratory strengthening and diagnostic technology evaluation. And this is across the diseases where FIND currently has its programs. Our governance is through a board of directors, and we also have a scientific advisory committee constituted by global technical experts. In 2021, we launched our three-year strategy, our new three-year strategy, and the overall focus of the strategy from an impact standpoint is to be able to have interventions or develop technologies which can enable us to save 1 million lives by ensuring access to quality diagnosis. We also want these technologies and interventions to be cost effective, with a target of saving about $1 billion in healthcare costs to patients and health systems in the low and middle income countries, and at the same time empower 10 plus countries with diagnostic data to inform policy and care. Going forward, as I mentioned in the previous slide, you see here a slightly complex slide. What I wanted to say is that this basically depicts the Access to COVID Tools Accelerator. So this was a global partnership that was put together in March 20 as an immediate response to the COVID-19 pandemic. And as you can see, it consists of a range of organizations across the public and the private sector, including the likes of the European Union, the World Health Organization, the Gates Foundation, and you have a whole bunch of country governments, as well as the World Bank and the Global Fund. So this essentially has three pillars. That is the vaccine pillar, the therapeutics, and the diagnostics pillar. The diagnostic FIND is the co-convener for the diagnostics pillar along with the Global Fund. And the principal idea behind this with this partnership was to be able to provide rapid access to vaccines, therapeutics, and diagnostics to ensure that they're rapidly developed. Efficient regulatory mechanisms are put in place. Globally, products are put on the WHO EUL, and the countries have all the information they need in order to have rapid access to these products and technologies. Very quickly on our three-year strategy, our long-term goals, they expand across the universal health coverage. And in support of the universal health coverage, our goal is to expand primary care testing to combat diseases that disproportionately affect vulnerable populations. We are targeting to reduce huge diagnostic gaps in tuberculosis, viral hepatitis, antenatal screening for both infectious and non-communicable diseases, fever, pneumonia, and neglected tropical diseases, which we believe will save lives, protect their livelihoods, as well as save the health systems a lot of money, enable a reduction in the out-of-pocket expenditure, and at the same time contribute to global and national disease elimination targets. Under the second bucket of health emergencies, our goal is to strengthen diagnostic surveillance and response systems to contain outbreaks and improve pandemic preparedness within the countries, essentially aligned with a One Health approach. Testing, as we all saw in COVID-19 pandemic, remains the first line of defense against the outbreaks, and which are becoming increasingly severe and complex. I think while we have been going through the pandemic, we're already seeing outbreaks like monkeypox and others across both the developing as well as the developed countries. We are working not only to address epidemic-prone pathogens such as SARS-CoV-2 and Ebola, but also the silent pandemic of the antimicrobial resistance, by improving access to AMR testing and surveillance to safeguard drugs and reduce mortality. So that in a snapshot is FIND's 3-year strategy. And our idea is to be able to work with country governments and partners, both in the public and the private sector, in order to achieve these strategic objectives. Very quickly coming to the rapidly increasing burden of infectious diseases in the Asia-Pacific region. While I think the Asia-Pacific region at large, and within Asia-Pacific, if we specifically talk about South Asia, the Southeast Asia, and also, countries like Philippines, which are in the Western Pacific, these are the ones which are grappling with multiple infectious disease burdens. And at the same time, there is also an increasing trend towards the non-communicable diseases. So what we say is the double whammy of communicable and non-communicable diseases. These countries, at the same time, are significant contributors to the overall global burden for HIV and TB. Viral hepatitis, both hepatitis B and C, it now accounts for the largest share of infections. And, and 63% of the global deaths, in fact, are happening due to liver cancer. And both Hep B and Hep C untreated, they are a major contributor towards the mortality associated with liver cancer. Another key cancer-associated disorder, that is cervical cancer, which primarily is caused by the human papillomavirus, is one of the leading causes of female cancer. While 16 of the 19 high-burden countries are in Africa currently, the region also currently faces a huge burden of this virus, which and the cancer, which if detected early, can definitely improve the treatment outcomes as well as the chances of survival of the patients. And further, while there is significant amount of mortality and morbidity associated with these diseases, all of these diseases have huge economic implications. And as we know, there is a range or there is a whole bunch of low and middle income countries which are already grappling with the severe economic downturn in the wake of the COVID-19 pandemic. And so this is just adding fuel to the fire. Very quickly coming to India and then switching to tuberculosis. India is the #1 country as far as the TB burden is concerned, and with 26% of the global TB burden. There are nearly 500,000 patients who are dying of this completely preventable and curable disease annually in India. It is also the leading cause of death amongst communicable diseases. One of the key aspects of the TB epidemic in the country is that India misses nearly 30% of its estimated cases. As you can see, in this table below, that on an annual basis, we are missing nearly 700,000 cases, and they keep on climbing year on year. India also accounts for 20% of the world's missing TB cases. In fact, there was a recent, and this was probably the first national TB prevalence survey in many years, conducted over a period of 2 years. It reported a prevalence of 312 cases per 100,000 population. And this was against a WHO estimate of about 188 per 100K. And which essentially means that the number of cases that were originally being estimated for India, this prevalence survey actually turned that figure on its head. So this essentially means that for every notified case, the survey also revealed that the actual prevalent number of cases was 2.84, which points towards the big diagnostic gap that we have in India. Even from a drug-resistant TB standpoint, as you can see, out of the globally 157,000 cases which were reported, nearly 50,000 cases were reported. So India has a 32% global share in the drug-resistant TB cases which are getting notified. I very quickly wanted to also talk about the impact of the pandemic. And as you can see from this slide, the 12 months of COVID-19 pandemic, in fact, put us back by almost 12 years in our fight against tuberculosis. Between 2016 to 2019, the number of new cases detected rose continuously. I think this was actually a positive trend that we were experiencing, but it fell dramatically by 20% in 2020. A lot of you would have seen, a lot of you would have reported on this number also in the newspapers during the years of the pandemic. The number of people who were newly diagnosed with TB and those reported and those who were reported actually dropped from 7.1 million in 2019 to almost 6 million in 2020. TB is now estimated to be the second leading cause of death globally, only after COVID-19. And from the contribution of India, India accounted for nearly 40% of this drop in the TB case notifications. And so when I say TB case notifications, it essentially means the cases which are getting diagnosed and also being reported to the National TB Program. However, the good news is that India is bouncing back as far as this fight against this drop in the TB case notifications on account of the pandemic is concerned. And this is largely because the country has a pretty strong foundation of TB services, both community-based as well as a very strong laboratory infrastructure. There is, as you can see from the slide on the, as you can see on the right hand of the slide, there is a pretty well established laboratory infrastructure, from the designated microscopy centers, which are about 20,000 in number, to the national reference laboratories. And there are various kinds of technologies which are established at these levels of healthcare, which are enabling rapid diagnosis of TB. One of the key challenges obviously remains is that microscopy is something which is not essentially the recommended diagnostics for diagnosing TB. It is because it does not pick up 50% of the cases because it is very less sensitive as compared to the other more advanced technologies. It is also difficult to diagnose TB in children through the microscopy. In addition, a microscopy test for tuberculosis also does not tell you whether this particular bug that has been diagnosed is resistant or sensitive to the first line of diagnostics. And hence, there is a critical need of having point of care sensitive diagnostics at the lowest levels of healthcare in order to improve the level of diagnosis. In addition to that, the government of India has established guidelines for bidirectional screening for COVID-19 and tuberculosis, which were developed during the course of the pandemic. There are existing guidelines which allow the integration of TB with both maternal and child health programs, the HIV program, as well as the NCD programs. There are strategies and guidelines which are in place to enable active case finding of tuberculosis in high-risk groups like people who are living with HIV, children who are less than 5 years of age, and those who are contacts of TB patients. Then very recently, and this was in 2021, that guidelines were established, and we will talk a little bit about this in our next slides. Guidelines around the silent TB or the latent TB. There are unpublished reports which indicate that nearly 40% of the population in India has this latent form of TB, and it is absolutely critical to be able to pick this before it develops into full-blown tuberculosis on account of other diseases like HIV or diabetes or anything that can bring down the immune status of the patient. So guidelines were established and there are right now interventions which are ongoing across the country around managing the silent TB pandemic around the TB infection. Plus, there are guidelines which are in place for effective engagement with the private sector, and there have been large projects like the Joint Effort for Elimination of TB, which was supported by Global Fund. This was implemented from 2018 and has just concluded in 2022. With the project getting transitioned to the state government, there is funding which is available through both the domestic sources as well as Global Fund to manage this transition and ensure that there is continuity of engaging the private sector. Plus, there are multiple interventions and guidelines which are in place to engage the workplaces as well as involve other ministries as far as India's fight against TB is concerned. So this is just going a little bit into a little deeper into the laboratory infrastructure as far as India is concerned. So the NTB's laboratory network, as I said in my previous slide, has been significantly scaled up over the last decade. And there are more than 70 odd labs which are supporting liquid culture. This is a rapid way of culturing the TB bacteria. And it also allows the laboratorian to diagnose susceptibility against both first-line drugs as well as the second-line drugs. And it is critical to know these susceptibility patterns in order to identify the patient as being sensitive as being inflicted with drug-sensitive tuberculosis or drug-resistant TB. There are another 74 laboratories which are certified for another technology known as the line probe assay. This is a slightly more advanced technique and is based on the principle of molecular diagnostics. And again, this accords the country significant capability to diagnose resistance for a range of first-line and second-line drugs. There is a very well-established external quality assurance program, which is across the both the molecular as well as the culture labs, the Gene Expert Network as well as the TrueNat network, and FIND has been actively engaged in the development of this quality assurance program. There have been efforts to introduce modern technologies like whole genome sequencing, and there are currently 6 genome sequencing labs in TB. There has been, as a lot of you would know, that substantial sequencing investments were made during the course of the pandemic, and there was this consortium of almost 38 sequencing labs that was established and was known as the INSACOG by the ministry. So there is hope that going forward that the country would be able to leverage this sequencing consortium of sequencing labs for the diagnosis of not just tuberculosis but other diseases with outbreak potential. In addition to that, FIND also supported in the establishment of a lab information management system to replace the paper-based reporting and enable direct transmission of the diagnostic test results from the laboratories into NICSHE, which is the central web-based data management system of the National TB Elimination Program. However, despite these efforts, testing remains a key gap. As you saw from the slide on the TB burden, India, there are 30% of the cases are still being missed, which are almost 700,000 on an annual basis. India also contributes nearly 20% to the missed cases globally. And these are primarily, reasons across the care continuum, ranging from poor patient awareness and access to testing at the primary healthcare levels. There is underutilization of the existing testing infrastructure, as you saw in my previous slides. While there is a whole range of technologies which is available across the country, but it is we have analyzed this through exercises like diagnostic network optimization, that all of these technologies are not being utilized to the extent they should be. Then there are inadequate sample referral linkages, which means that the patients who are accessing care at the primary healthcare level, their samples are not being referred in a timely way. In some cases they are, in some cases they aren't. In some cases the patients themselves are being referred, which is a relatively inefficient way of ensuring access to diagnosis. And last but not the least, there has been up until last year a relative lack of TB infection testing, and this is what points to the silent TB or the latent TB infection. We'll talk a little bit about the various interventions that are currently ongoing or can be put in place across these 5 gaps. And as I said, testing obviously remains the weakest link in the care cascade and then needs to be urgently addressed. So the first challenge is essentially solving for the poor patient awareness and lack of access or limited access to testing. As I said, early diagnosis and treatment are key drivers to attain the TB elimination goals of the government of India, and this really needs a very active multi-stakeholder collaboration spanning across the public sector, private sector, and dealing and working very closely with the community. From a private sector engagement, I spoke about the project JEET, which was implemented from 2018 up until March 2022 and has now been transitioned to the government of India. So it is absolutely critical. This project was a huge success, and it enabled a very efficient involvement of the private sector, right from pharmacies to individual providers to large hospitals to small nursing homes to standalone laboratories as well as chain diagnostic center chains, and ensured that the TB cases that are being diagnosed within these settings are being actively notified to the government of India. There are additional opportunities around building capacity for the management of drug-resistant TB in the private sector, despite the fact that there is significant infrastructure in place within the public sector. As we all know, that there are large swaths of population which still access care in the private sector, and hence it's absolutely critical to ensure that the private sector is diagnosing and managing TB cases in line with the standards of TB care of the Government of India. Then on the other side, it is absolutely critical to involve the community. And the reason I say this is that that people listen to people. We have seen this in neighborhoods, we have seen this in, RWAs, and we saw how the community rose to the challenge of the COVID-19 pandemic when the government was facing limitations in terms of providing access to oxygen or diagnostics or therapies. We all saw the power of the community, and there are a lot of projects and there are a lot of strategies which are right now in place, and the government is very actively supporting interventions which are led by the community for the community. And these community-led interventions are focused around increasing awareness about the disease, as well as also efforts to increase access to diagnosis and adherence to treatment for those who get diagnosed in order to ensure proper treatment outcomes. Then there are certain, new age community-based testing models. And some of these models, as you see on the far right of this slide, there is these portable X-rays which are now becoming available, and you can actually carry these X-rays into the backpack. These are AI enabled, and you really do not need an expert radiographer. The image that can be clicked at the community level can be transmitted or either to an expert radiologist or can be interpreted through a computer-aided diagnostic algorithm. Then there are efforts which are ongoing in order to further increase access to testing, both at the community level as well as the primary healthcare level. There are tests which are, high sensitivity urine-based tests, which are, so instead of using sputum, which is a very difficult and not necessarily the best sample for diagnosis of TB, there are now tests which are available and are being further improved, and which use urine as a sample to diagnose TB. Then there are efforts on to look at various other sampling technologies, including aerosol-based samplings. For example, there are strips which are now being placed within the masks. All of us now are very familiar with the use of the masks thanks to the COVID-19 pandemic. So this technology or this particular PPE is now being leveraged to see how you can actually capture the TB bug and then subject that further to diagnostic testing. Coming to the second, which is essentially solving diagnostics across the levels of care. As you see on this very busy slide, you can essentially split this into three categories. So one is the cartridge-based diagnostic technologies, and this is essentially here the Gene Expert and the MolBio TrueNat are the flag bearers of this technology. Gene Expert, as we know, is the most common technology, but over the last few years, TrueNat, which is an indigenously developed technology, has really taken rapid strides, and they're not only now are well established in India, but are also spreading themselves into the other countries. You then have another range of technologies which are sort of intermediate throughput. And this is something which can be installed at district hospitals or at intermediate reference labs. And these are again multiplex technologies. As you can see, you have this platform by ST Biosensor. A lot of you would have heard of this company as they had that rapid test which was made available for antigen testing for COVID. Now they are working on a 9 assay menu, which includes not only drug sensitive TB, but also first and second line drug resistant TB. So FIND is working on trialing this technology in 2022. There is another Korean technology known as the Bioneer Iron Q, which again has a very extensive menu. It is an RT-PCR, qPCR based technology, again, ready for trialing in 2022. Then on the far right, you see on the top right-hand corner, there is a whole range of high throughput technologies, which also includes the Roche Cobas. And these technologies have now been approved by WHO. And there were a lot of these platforms which have gotten into the country thanks to the investments on account of the COVID-19 pandemic. But as a next step, it is absolutely critical to ensure that these technologies get utilized, as these technologies are not only highly sensitive, they are very high throughput, and more importantly, you can diagnose multiple diseases through these platforms. Then, going below as you see on the bottom right hand corner, we are also working on technologies which can actually enable you to understand the nature of the bacteria, whether it is sensitive or resistant, straight from the sputum, that you don't need to culture it. And these are miniaturized technologies that we're working on. And there is an end-to-end solutions review, which is planned by WHO in 2022. And these are all sequencing-based technologies. So which essentially means that, if these, right now the challenge as far as TB diagnosis through sequencing is concerned, that there is no regulatory approved assay for diagnosis of TB using sequencing techniques. Sequencing is largely recommended for surveillance purposes, as you saw, for in the case of COVID-19 pandemic, where sequencing infrastructure was rapidly put into place to identify variants of concern. So we are hopeful that there is a whole range of technologies and which FIND would essentially enable a review through WHO, and those will become available. The pipeline for the TB technologies looks very robust. We did a landscape review of 155 true point of care platforms. When I say true point of care platforms, is something which is right at the bedside, or something like a rapid antigen test, like you saw, or a rapid pregnancy test. And then there are the near point of care platforms, which is the Gene Experts and the TrueNAS of the world. And there are quite a few more in the pipeline. And in addition, there are several other TBSs which are in the pipeline. So from a diagnostic standpoint, it is really looking exciting from a pipeline perspective. The third key challenge that we need to solve for is the underutilization of the existing testing infrastructure. And this essentially involves an approach which we call as the diagnostic network optimization. So the diagnostic network optimization, or DNO, it essentially aims to understand that how the diagnostic services are organized in the country, which means which technologies are available at which level, what kind of patients are accessing these technologies, how far or close these technologies are to the patients, and what are the kind of sample referral systems that are currently in place in order to ensure appropriate utilization of these technologies. So this network optimization essentially uses national data in order to understand the existing gaps that are limiting access or are limiting the utilization of exercise, and at the same time comes up with models and solutions which are best equipped to address these gaps. So in India, there is a large diagnostic network optimization exercise which is currently in play. And as you can see from this schematic on the left hand side, it essentially involves looking at availability of facilities at the testing site, looking at a hub and spoke model, for example, something like a digital level facility, and then also looking at a health facility like a primary healthcare center or sub center where the patient is accessing. So you're essentially looking at how you can create a network out of these health facilities, as well as testing sites and large diagnostic hubs, in order to ensure that these technologies are appropriately utilized and are linked through a sample referral system. It is absolutely critical that this is an exercise which is done on a regular basis. It is right now ongoing in about 50 districts in India through a Global Fund enabled project, which FIND is leading, working closely with the National TB Elimination Program. And we are trying to take the technologies or the install base of TB diagnostic instruments that are available in both in the public and the private sector to ensure that we can come up with models that can enable appropriate utilization of these technologies. As I spoke earlier, there are a lot of the multi-pathogen testing platforms that have become available thanks to the investments on account of the COVID-19 pandemic, and it is absolutely critical to ensure that this capacity and the multi-pathogen diagnostic capacity is leveraged, and they are included in the network optimization exercise from a planning standpoint to allow and enable access at across levels of healthcare. And then the other bit, once you have the network optimization models in place, you also need to solve for the sample referral linkages. And there are right now a whole bouquet of sample transport solutions, including the age-old TB volunteers, the couriers, and the postal services. And now, there are drone services which are also being trialed in particularly hard-to-reach locations. But I think the overall idea here is to be able to look at a mix of or a bouquet of services. No one size would fit all. I mean, you need to look at solutions which would fit the kind of geography or the kind of level of healthcare you're looking at, how distant or close the technology is from the basic or the primary healthcare facility, in order to ensure that you are not only able to send the samples, but are also able to track these samples in real time, and also ensure that they are, when they're being sent and they're being received, they are shipped appropriately in appropriate temperature conditions, and you're also able to receive feedback from both the testing lab on the sample quality and acceptance, so that in case a sample is insufficient or was not sent in the proper way, the information can be sent back to the referring lab if a repeat sample is required. Last but not the least, solving for the TB infection testing. There are more than 15 new tests which are now entering the market for TB infection detection, and this is largely around diagnosing the disease when it is still latent and is not full-blown tuberculosis. This is an absolutely essential strategic component in order to ensure that India reaches its TB elimination goal. And it is in fact great to see that the government of India has stepped up its efforts around management of latent TB, and this is through a version 2 of the JEET project, where right now partners like organizations like FIND and Clinton Foundation and Union are working together to scale up access to latent TB and test and treat services across the country. So if you look at the technology map, you have solutions of all kinds which are becoming available. There are obviously the high throughput automated solutions meant for centralized testing facilities. Then there are ELISA-based IGRAs, which are obviously more common. But so far there were limited number of suppliers, so the number of suppliers is increasing, which would increase the competition and hence work to reduce the cost of testing, which is still pretty high in India, almost 1,700 to 2,000 rupees to the Indian patient. Then there are certain RDT-based IGRAs. When I say RDT, it is rapid diagnostic test, or a card-based IGRA, which requires a small reader, but again would enable diagnosis at a very rapidly. But the challenge with the RDT-based IGRAs and other IGRA solutions is that they still require a blood sample for diagnosis, which at times can be very tricky because these facilities are not available at in smaller cities and in remote districts, and hence it's important to establish those sample transport linkages to be able to send them to labs where the diagnostic facilities are available. So in order to sort of mitigate that challenge, there is a specific class of skin tests which have just been approved by WHO. And the good news is that Serum Institute of India, in fact, will now be commercializing a new skin test, which is right now undergoing trials by the Indian Council of Medical Research. And if this is something which can be successfully launched in the country, this can significantly bring down the cost of testing as far as latent TB is concerned, because this will be available for a few rupees as compared to a few thousands that you need to spend for IGRA-based tests. So the key takeaways as far as this conversation is concerned is that it is critical to have strategies that can bridge the testing gap and enable finding these missing cases and break the chain of transmission. For this, it's important to increase public awareness through community and public and private sector engagement channels in order to drive the demand for testing. It is also critical to maximize the use of both available and new multi-platform and cartridge-based molecular diagnostic technologies, thanks to the COVID-19 pandemic, as well as other investments that have been made prior to that. Continue to explore new point of care and non-sputum based testing and sampling methods, because this is something which will really make it easy for the patient as well as for the laboratorian and the physician to be able to access the results and rapidly link the patients to treatment. Look at optimizing the placement of new and existing testing machines, explore multi-pathogen testing models, and established robust sample referral systems to ensure that all those who need access to diagnosis have that access. Continue to increase the engagement with the private sector and fortify community-led models, and also look at scaling up finding and treating TB infection or the latent TB cases, especially in the high-risk groups. So with this, I'll end the presentation. Happy to take up any questions.
Yeah. Thank you, Dr. Sareen. I think it's a very comprehensive presentation, and I think you packed in as much as possible in the half an hour time. Thank you very much for sharing your insights with us. I think there are a couple of questions that come up. One is talking about latent TB. What are the factors? I think the question from Sushmita from Financial Express. What are these, some more insights on latent TB, and then why India is, contributing to the largest share of TB burden in the world. So can throw some light on that.
Yeah, sure. So I think first answering this question around latent TB. I think this problem has been there for a number of years now. It is now that and that is in fact one of the contributing factors to India being number one as far as the TB burden is concerned in the country, because if you have more patients who are suffering or who have latent TB, then all it takes is a trigger like anything that can bring the immune status down. And this could be something like diabetes, or something like flu, or any respiratory illness, or HIV, and the only factors which are keeping this hidden TB to bloom into full-blown disease is the immune status of the individual. As long as these individuals are healthy, I think they're able to keep the disease under check. But the moment the defenses are lowered, it rears itself into a full-blown disease. And this is one of the, has been now recognized as one of the key contributors to the high disease burden that India has as far as active TB is concerned. Now, some of the other factors which are the cause for this high TB disease burden is number one. Despite the fact that there have been a lot of efforts both by the public and the private sector on increasing awareness, there is still not as much awareness as is needed around tuberculosis. People still continue to ignore, very basic symptoms around tuberculosis, like, loss of weight, or loss of appetite, or loss of, or having fever over a period of time, or over 15 days, or something like having cough, untreated cough over a period of time. People are still, trying to manage the disease either at home by buying over-the-counter antibiotics from pharmacies, or sometimes going to informal practitioners. It has seen that there is now data to show that it, on an average, it takes almost 6 months for a TB patient to be diagnosed. And so you can imagine that during the course of these 6 months, this person who is carrying the bug is likely to infect a whole bunch of other individuals, more importantly within the households. And then those who are getting infected within the household, they're obviously traveling out, and then there's a whole chain of transmission that is happening. So absolutely critical to ensure that the patients are aware of the symptoms, and they get themselves tested at the nearest available diagnostic facility. And the good thing is that the diagnostics is completely free of cost right now as far as the India's national TB program is concerned. I think there was another question around
population screening.
Yeah, population screening. So over the years, it has now been seen that population screening is not necessarily the best way to diagnose TB. Even in a high disease burden like country like India, the active case finding strategies have now been super refined, and in fact, they focus largely on the high risk populations. For example, those who are living in slums, or those who are living in tribal communities, or crowded places, and especially focusing on patients which are high risk patients, like people who are living with HIV, or people who have any kind of immunodeficiency, either by virtue of HIV or other non-communicable diseases like diabetes, and who are suffering from cancer, or renal disorders. So the program is actively looking at targeting their active case finding strategies to these key populations in order to increase the yield. And the other, the sort of a more recent thing over the last few years has been the introduction of more, or the use of more sensitive technologies for diagnosing TB in these populations, because earlier smear or verbal questionnaires used to be the primary method of diagnosing TB in these cases, and as a result of that, they would miss a lot of the cases. So So the long story short here is that it is critical to be very strategic about the active case finding strategies, and focus them on critical geographies and critical populations, and ensure that you're using sensitive technologies while implementing these active case finding campaigns.
Yeah, Doctor, maybe we'll take just two questions. So we are running out of time. One is, we had shared a lot of data on TB, and is there something available on the Fine's website? Because there'll be a lot of good resource for journalists to cover the stories in the paper and another media.
Yeah, no, I can separately send links to the Roche team, and they should then be able to share it with the journalists for them to be able to. There's a lot of information available on the Fine website. There's a lot of information on WHO and GLI and a whole range of other websites is available in order to access this information both nationally as well as internationally.
Okay, thank you. And maybe one last question from Sanjeev Das asking about, is there any link between COVID and TB?
I mean, I wouldn't say that there is a link, but the fact that both of these are essentially respiratory illnesses, so there is a lot of similarity in the symptoms as far as COVID and TB is concerned. I think especially from the fact that there is cough, and essentially there is fever, and so the diseases mimic each other in a certain way. And that is why, at the peak of the pandemic, government came with these guidelines around bidirectional screening of COVID and TB. And the reason for doing this was that anyone who's coming in with a sort of a cough, the mandate was that they should be screened for COVID. And if, found negative for COVID, they should also be screened for tuberculosis. And the other reason they wanted to do this was, as I showed in my slides, that the TB pandemic was that TB was badly impacted by the COVID pandemic. There was a drop in notifications. People were not, going to the facilities and accessing testing on account of lockdowns and account of fearing COVID infection in the hospitals. Hence, the government wanted to bring this, entire TB piece back on the track, and hence, the need. But I think what is important, going forward, is to have these integrated respiratory disease screening packages. So you are not looking at the patient, already pre-identifying that this patient could have COVID or TB. So, I mean, the approach should be that when a patient walks into a healthcare facility with a cough, you should apply, all sorts of diagnostics in order to ensure that the patient it could be something like a chronic obstructive pulmonary disease, it could be tuberculosis, it could be just viral cough, it could be COVID, it could be TB. So it's important that you send the patient back with some kind of a diagnosis, and this will also improve the confidence of the patient in the health system, and at the same time ensure that the patient gets managed well, and the symptoms are ameliorated.
Okay, thank you. I think questions keep coming in. Maybe one last question, and then we'll wind up after this. And asking about why there is still a gap between notification and how to address it.
So I think the bulk of my presentation, in fact, was focused on why there is a gap in this case notification and how it can be addressed. In fact, the last 5 slides were completely focused on the various strategies that can be implemented in order to mitigate this case notification. And I already mentioned the challenges are technology-based, challenges are lack of awareness, challenges are lack of involvement of the community and the private sector, which are leading to this gap in the case notification. Then also the fact that a lot of times the patients are diagnosed, for example, in the private sector, and they're not necessarily notified to the program, despite there being a law that, TB is a notifiable disease, and wherever it gets diagnosed, it essentially needs to be notified. So that's the gap which projects like JEET were trying to plug by building a system which enables easy notification of cases wherever they are diagnosed into the government system.
Okay, thank you very much. I think it's really a very informative session. In a short time, you address a lot of points. I'm sure that you will see more reporting on how to address public health systems in our medium. And thank you for joining us today. And I'd like to thank Roche Diagnostics for the support to the program. And it has been indeed a very good service for the cause of journalism, and also for the health improvement around the world. Thank you all. I'd like to thank the colleagues from Roche Diagnostics, Anil and Sanjay Singh, for coordinating and for your support. And with this, we come to the end of the sessions. Now participants can leave the meeting, and we hope to see you again, and then we'll send you access to some data whenever it's available. And we've been a fantastic audience today. Thank you all. Bye-bye.